Hello. Hello, dear Lisa.
Hello,
My dear
Heidi.
Ron, how are you?
Hey,
He
Ron.
says, Joseph, Servus, wie geht's,
Gut,
Joseph?
gut. Ja, ja,
Well,
gut.
hello.
Hi.
Hi.
Ismail,
Hi.
hello, how
Joseph.
are you? And we have some guests also. Varku, hello. And well, such a nice congregation. Harmut, Banu, hello. Ofer, my dear, many kisses, my dear Offer. We think of you all the time and we wish you the best, my dear. I'm very happy to see you. Very, very happy. Well, now we are going to begin with our 27th online session. And congratulations for a wonderful World Boys Day. It is not a day, it's a month. So all the month we are going to celebrate World Boys Day. And this is great to have you. And I thank you very much for your great contributions because the presentations are really very, very good. Thank you very much, dear Liza, dear Austin, dear Joseph, dear Ismail, dear Pedro, dear Jacobo, dear Eugenia. So thank you very much for your contributions. And as you know, we have the program also for all this year. And I wait for you on the 11th of July because we are going to talk, and this was a nice proposal from our dear Liza, superior laryngeal nerve diagnosis and treatment. And I have been organizing that, so you are very welcome to send your proposals in order to have this very interesting topic. And 5th of September, we shall have care of the artistic voice professionals. And this is also a webinar for all people. Of course, every person can come and look at our online sessions. And then we shall have our annual conference. And I hope you all can come to visit our dear Catherine Neumann, that she is going to be the president in Münster, Germany. She's already organizing the program. And so we shall have a very nice activity year.
And
Next
salt.
one, please. And as you see the program, the next one, Karina. And the program for today is really wonderful. We have Austin King, what to expect when referred to a voice doctor. I'm going to talk a short ideal examination for artistic voice students. Our dear Liza, a very nice comparative breath support strategies. Jacobo, very interesting professional voice disorders, when to and not to operate. Our dear Joseph, what is the contact granuloma telling you? Is telling us many things, dear Joseph. And Ismail with a wonderful touch of laser reduction glottoplasty for voice feminization. Our dear Pedro is going to show the celebration that the voice makes from Amalia Rodriguez, a globalized fado acoustic phonatory characteristic throughout her career. And Ramon Hernandez is going to talk about voice biomarkers in singers. So as you see, it's a very nice program. And I thank you very much for your assistance. And I hope you enjoy as much as we all do together. Don't forget, as Comet Family, we belong to these presentations. As you know, Austin King is a co-founder of the Voice Institute of West Texas with a team consisting of a laryngologist, speech pathologist, and vocal pedagogue. He's active since 1984, and he's preparing at the moment History of Comet. I'm going to read only 2 lines from each curriculum, but as you know, we have the complete curriculum in our webpage when you gave the permission. Okay, let's hear Austin. Thank you.
I'm Dr. Austin King, a laryngologist, and I want to welcome you to World Voice Day, where we celebrate the wonders of the human voice. But unfortunately, occasionally, people will have problems with that voice, and that's what I'd like to visit with you today. If you have problems such as hoarseness or changes in your voice that last more than 2 weeks, oftentimes the primary care physician will then refer you to a specialist who treats the voice box or larynx and voice problems. And oftentimes, the anticipation of what will happen during that examination is worse than the examination itself. And so that's what I want to visit with you here today. You'll be referred on to a specialist in the United States or some countries. It's a ENT or ear, nose, and throat doctor that we call an otolaryngologist or a laryngologist, and that's someone that specializes in just the voice and the larynx. In Europe and other countries, you can be referred on to an ENT or a phoneotrician, which is a medical doctor that specializes in disorders of the voice and speech and larynx. If you're referred on to a ENT doctor, they're responsible for everything in the head and neck area, and they will do a complete exam of the head and neck area, feeling your neck for lumps, looking in your mouth, nose, and ears. And if you're referred on for something other than voice, such as your ears, they'll do a cursory examination of the lower throat and voice box, and they'll use a mirror, and they'll go through your mouth, and then use that to look down on the lower throat and the voice box. Now, if you are referred for a voice complaint or voice problem, then they will do a much more thorough examination of just the larynx. And they will use what we call a fiber optic laryngoscope, where they will go through the nose and they will spray your nose with some medication to shrink things down and numb things up. And then the instrument goes down the back of the palate, where it can look at your voice box or larynx while you talk, or if you're a singer, while you sing. Now, if during that examination they're suspicious of a problem underneath the covering of the vocal cords, which they can't see, or perhaps a partial paralysis affecting the vibration of the vocal cords, then often they will use what we call a stroboscope, which is an instrument that's synchronized with the vibration of the vocal folds and can actually slow down their function, where you can watch individual wave formations or even stop the movement of the vocal folds completely. And that allows a diagnosis of problems affecting the vibration of the vocal folds. Now, sometimes when they do that examination, they will also use a little bit different instrument which gives a better resolution, which we call a transoral laryngoscope, that goes through the mouth and has a light attached to the stroboscope, and where you can look down at the vocal cords directly, and like I say, get a little bit better resolution. Now, if they cannot diagnose your problem using these basic instruments, and especially if you're a professional singer or actor, then they can refer you on to a voice lab where they have much more sophisticated instrumentation. So I hope this will answer some of your questions if you or when you get referred to a voice specialist, that the exam is not painful and doesn't even have needles. So wishing you a happy World Voice Day, and hopefully you'll never have to use this information. Thank you.
Thank you very much, dear Austin, and I welcome you. I'm glad you are here. And I want to welcome our dear Alan Burma from Tallinn, Estonia, our dear Katrin Neumann from Münster, Germany, and our dear Jana Montecalvo from Italy. Ciao. Jacobo Caragama from United Kingdom. Welcome you, and welcome to our other guests, Jorge Treviño. And of course, I welcome very dearly our dear Tom Harris and Sarah Harris. Thank you very much for being here. So let's keep on with our program. Thank you. So I am a medical doctor, and sorry, and I am a medical doctor in phoniatrics and audiology. I have a fellowship in respiratory allergies and also some other fellowships. I'm founder of the Centro de Foniatría y Audiología in Mexico City, and I am the president of COMET from 2019 to 2022 and from 2022 to 2026. And I am the national coordinator of World Voice Day Mexico since 2000. Thank you very much. I am very glad to talk to you about ideal examination of artistic voice students. This is very important because, as we know, not everybody is in good shape to develop what a conservatory or a theater acting study demands. So we are going to understand that in theater singing or dubbing, the examination is important because these students need to have different structures that anatomically and physiological work in a good shape. The physical and artistic characteristics of the students need to be adequate for the activities. First of all, we need a medical story, and also we have to talk about the artistic background. If they have already have some education in artistic voice, either theater or singing. The complete examination belongs to the phoniatrics, and we need to make a medical phoniatrical examination. In our team, there is also a logopedist, singing or acting teacher, and psychologist. The medical phoniatrical examination mainly examine anatomical and physiological signs, but focus on the artistic activities. First of all, the auditive perception of us with the student. How is the volume? How is the frequency, the timbre, and the rhythm by speaking, and of course by singing, if there is a singer possibility. We need to look at the posture, at the movements when they are walking, when they are trying to sing, in order to sing how is the movements of the head, neck, thorax, and of course the movements of the legs and the arms. We also examine very carefully the face, the neck. The mouth is very important because we have several structures that can be not in a correct shape, like the oral closure, the teeth position, and of course, very important, temporomandibular joint. When we are going into the pharynx, we look at the soft palate, at the uvula, as we see in some of these slides. The uvula is very big, is almost touching the tongue. And of course, this is a disadvantage in order to have a better resonance chamber and also to avoid oral breathing. That's why, for example, in this patient, we made a remodelation with radiofrequency to take away all the very hypertrophic uvula. And of course, we need to look at the tonsils, like here, and at the pharynx,
Aye.
also at the movements,
Aye.
because as we know,
Aye.
the movements are very
Aye.
important, mainly from the
Aye.
soft palate, but also from the tongue. The next very important examination is a laryngeal rigid endoscopy, either 70 degrees or 90 degrees or flexible. In my experience, I prefer to make rigid endoscopy of 70 and 90 degrees, both, if the patient allows. But many colleagues, they also use flexible. So we can have different views. For example, here, when we have a compensation of the ventricular muscles, and even though this compensation, we don't have a proper glottal closure. Here we have a very rigid glottal closure And in this 70 degrees endoscopy, you can notice the arytenoid esophageal region. And here in this student, you have a granuloma, another granuloma, and of course the vocal folds have to look like this slide. And the next one, very important examination, is stroboscopy. Since Schoenherr, Timke, and von Leyden, we knew that was 1957 that synchronolaryngel stroboscopy was very important to make a proper diagnosis of the vocal folds physiology. So let's look at these slides. As you see here, we have the opening and closing phase, and also we have the undulatory wave in order to see if there is a proper closure in all the registers. And here we have also the 70 degrees endoscopy. Here's another patient that also has some edema of the body of the vocal folds. Here is a better closure, but we do have in the vestibule and in the arytenoid area some redness. And in this patient, we have an edema in the vocal folds edge, and that means that the singer or the student cannot have a very brilliant voice because of this slight edema. We have here another cases where we find more inflammation on the vocal fold free edge, and that avoids to have a proper glottal closure as you see here in this stroboscopy. And of course, some of the very important characteristic of the singing voice or the acting voice are missing. Here we have another lesion, is a bigger lesion, nodules, and they are very thick and also very hard. And here is a tiny inflammation that, of course, with a proper pharmacological treatment and with a proper rehabilitation exercises, it goes away without any surgery. But also we have in these cases, in this last case, we can look that the glottal movements are not really the proper ones. So we need to keep on with our study examination of the nose. Usually we make that with the flexible nose endoscopy. For example, here we have some characteristic of this student, and of course, many times when we find paleness or hypertrophy of inferior turbinate or some septum deviation, we ask for a tomography like you see in this. Very important is to have ear endoscopy and also to perform an audiogram, because many of the students, as we know, is possible that they have some ear damage. So it is important that we look also at the mobility of the tympanic member. So we can see here that the illumination is a proper one. Acoustic analysis and phonetogram are compulsory for our artistic voice students examination. Like we see here. So we can look how are they making the correct dosification of the air column, how is the placement, and how are the harmonics of his or her singing. And of course, we have also acoustic analysis and phonetogram for theater and dubbing students. The aerodynamic studies are important, but we do not perform them all the time. But they are very, very interesting and important because we have the closing and opening phases of each vibratory cycle. The lungs examination is compulsory. If necessary, we need a spirometry. And we need to look very careful of the breathing pattern of each of the students. In laboratory, sometimes we need to have blood test, tomography of the nose and sinuses, radiography of lungs, and sometimes a series of radiography of esophagus, stomach with, of course, a barium middle. The musical examination, even though in our group there is a music singing teacher and acting teacher, we also perform that in order to have a perfect idea about the possible classification of the voice. How is the breathing? How is the support? How is the dosification of air column? The resistance of the voice, mainly in theater. They used to perform some reading, of course, some of the phrases or paragraphs of Shakespeare, mainly Romeo and Juliet. How is the vocal range? How is the tessitura? The placement, the flexibility is very important, changing in the different register, changing the passaggio notes. And how is the agility with squareness and toning? Of course, in the theater, we need to look very carefully at the articulation because many of these students have articulation problems due, for example, in Spanish, they cannot pronounce properly r, they pronounce r, like in English. So it's very important that we really prove that the articulation in the mother tongue is a proper one. And of course, the emotional intentionality, mainly in theater, but of course, also by singing. So, dear friends, in conclusion, this ideal examination asserts that the anatomical and physiological artistic capabilities will allow for the proper development of the artist. And this is very important because we have to think about all the efforts from the students, from the teaching group, from the director, and of course, the artistic development that we can have a better or we can damage our student. Many dear greetings from Mexico City, and thank you very much for your attention. And happy World Boys Day. So now we have our dear Liza with this very interesting comparative breath support strategies. As we know, she's a Master of Fine Arts since 1981 from California Institute of the Arts. She has a major in voice as Bachelor of Fine Arts since 1979, and also she studied in California Institute of the Arts. Her majors in general music, voice, piano, and she's also the founder in Los Angeles Voice Works. And as you know, she has many research programs. She has published a lot of books and articles. So it's a great curriculum. Thank you very much, Liza.
Hi, everyone, and happy Voice Day. I'm happy to share with you some thoughts on comparative breath support strategies. What is support? This term is short for abdominal breath support. Simply put, support is the action of thoracic and abdominal muscles to pressurize outgoing air to vibrate the vocal folds. The history of the concept begins with the Italian term appoggio, meaning lean, and was first used in vocal pedagogy by Francesco Lamperti. He said that support is the slowing of the rise of the diaphragm by actively controlling the back and abdominal muscles which act upon it. His son Giovanni defined it as singing on the gesture of inhalation. So there will be an antagonism between inhalatory and exhalatory muscle action. But how? Though most pedagogues believe that breath support is foundational to healthy, controlled, consistent voice production, there is no agreement on how to teach it. And that's a problem because inadequate or incorrect support action tends to result in compensatory tension. Here are lists of various types of compensatory tension that are not necessarily fixed simply by relaxation. The work needs to come from below. Also, there are a number of confusing terms that have traditionally been used in vocal pedagogy, including use your diaphragm, tighten your abdomen, engage your core, resist my hand. One of my favorites, don't sit on your voice, anchor your pelvis, sing from below, sing from your stomach, push down when you sing. Another confusing phenomenon is that the term breathing has often been used in teaching to mean not only the intake of air, but the outgo of air under pressure, meaning support. Breathing and support are not the same thing. For voice instruction, for speech and singing, it's best, I think, to use the term breathing to mean the air coming into the lungs when not singing or speaking. And the term support should be used to mean the pressurizing of the outgoing air for singing and speech. Here are some support methods that I've encountered in my long vocal journey. Rib cage expansion only is still taught in the classical world. I don't think that it is adequate, but it is a good start. Sternum lifting is a strange, unique method that I have seen in action only a couple of times. And in this, you raise the chest up to a horizontal table-like position for breathing, and then for support, you continue to push it up. I had the misfortune once of watching a professional tenor crack very obviously in a performance when using this method. Many teachers, if they use the term abdomen at all or abdominal, they think of the abdomen as one thing, but I think it's best to separate the upper belly from the lower belly. The lower belly would be the navel and just below. And to me, they have two different jobs. Here are some various strategies that I've encountered, and then I'll share with you my favorite one. For the upper abdomen, there's resist the fist, which is really a passive way of contracting it in. There's another way that's useful for some people where you put two hands on either side of the rectus abdominis and you push them out. My favorite way that seems to work for everyone, it's hard to say, but it's been my experience, it's the game changer, is to gently firm out the center part that I call the magic spot. This area should be gently firmed out, spongy firm in texture, or like a trampoline, not hard as a rock, and it should stay out for the entire sung phrase or spoken phrase, particularly if it's projected speaking voice. For the lower abdomen, I've heard the direction do nothing. Take your lower belly and pull it in and down. Take your lower belly and pull it in and up. And I think this accidentally pushes the upper belly out, so this works for people, but I don't like things to be that accidental in vocal technique. And the one that I think works the least well for most singers is to take the lower belly and to stick it out and down. This tends to result in a difficult, strainy, reedy, tight-sounding higher range. My favorite way is to take the lower belly, again that's the navel and just below, and to gradually clutch it straight in towards the spine for singing, and then to relax both abdomens, upper and lower, for breathing. But basically focusing on the lower belly, pull it straight in gradually for singing, and let it relax for breathing. There are some other unique pelvic strategies. The dump, which is pushing down on the pelvic floor towards the back. There's the diaper, which is to push on the pelvic floor in the middle part of those muscles. And one memorable technique is try to feel constipated when you go for loud high notes. Not my favorite method. Having a red face while singing is quite distracting. It's an accidental way that must work for someone, but it didn't work for me. There is a waist strategy that works for some singers and not for others. So for me, it's optional. It's not one of the basic 4 support methods that I'll share with you in a moment. For those for whom their waist will go out, some people's small of the waist area doesn't move, which is not a problem. But for those that this works for, it can be really a beneficial approach. And for this, you put the hands on the small of the waist, and for singing, you push the waist out. And even though I probably shouldn't say it, I've also had some remarkable results with a few clients who suffered from spasmodic dysphonia. To push the waist out resulted in smooth speech. I would like to further investigate this. There are some non-support and non-abdominal support methods. I had a teacher who was world-renowned who is anti-support. He said, if you ever have a teacher who mentions support, run, because the vocal cords can take care of themselves. I heartily disagree with this and had several students come to me from this teacher with nodules. Another unique approach is that no abdominal action is required. Just stick your neck out to anchor your voice. When I try this method, it makes my neck hurt, and it does produce a very clear, loud sound, but doesn't seem to be able to help me support softer notes or sweeter sounding notes, just loud. This next one, the head pushback, I've found very helpful, specifically for belters. And in this, you push the middle of the skull in the backwards. It seems to activate the muscles, the vertical muscles on each side of the cervical spine, and it helps to stabilize the voice box. Some people benefit by expanding their latissimus dorsi. It helps to create a gentle and comfortable lock on an expanded rib cage. My favorite support method after much experimentation is the following. For singing and speech, keep the chest high, comfortably high. Don't let it drop when air leaves the body. Job 2, try to keep the side and back ribs comfortably wide. Don't let them collapse. Job 3, upper belly magic spot again firms out for the entire sung or projected speech phrase. Job 4, lower belly gradually clutches in for voice and releases for breath intake. Here's some interesting ones I've heard and have used on occasion for power and easy high notes. There's the hug a tree, which creates a pelvic tilt, similar to the instruction of reaching out and imagining that you're holding a large beach ball. Some singers, particularly opera singers, like to squeeze their buttocks. I have used this method, the squeezing of the inner thighs for certain notes. The push-a-piano is a traditional method that I don't like very much because it tightens the bellies and the neck. What I do like is this idea that it makes you feel like you're using your whole body, but there are better ways to teach that. Toe gripping, rather odd and humorous, but I have used it particularly for high belty notes. And then you have to relax them when you're not singing high and belty, otherwise your toes might cramp. Here's a QR code for you if you would like to have this presentation in a PDF format. It's connected to my pCloud account. Thank you for your attention, and I invite you to reach out to me if you'd like to discuss this topic further. Thank you again, and happy World Voice Day.
World Voice Day, dear Liza, and thank you very much for your patience. And now I'd like to say hello to my dear Sarah Amris. I see your lovely face there. And hello, Pedro Pestana. I'm glad you are here because you made a wonderful presentation that we are going to hear. And Deborah is here also from Greece, and also our special guest, Dr. Lara from Mexico. Thank you very much for being here. Now, I would like to introduce just a few lines about the wonderful curriculum from our dear Yakubu Karagama. He's a laryngologist based at the Geese and St. Thomas Hospital in London. He's an honorary fellow at the Royal Northern College of Music, Manchester, and an expert in management of professional voice disorders using latest minimally invasive endoscopic endoscopic laser technology and cold steel. So we shall hear Yakubu, professional voice disorders, when to and when not to operate. Thank you very much for being here, Yakubu, and for your presentation.
Hello. Thank you for having me today to speak to you about surgery in professional voice users, when not to and when to operate. When you see a patient with vocal cord disorders in professional voice users, especially, or any surgical treatment, you need to consider certain factors. But most especially in professional voice users, the type of lesions will determine whether these patients may go on to have surgery or whether you can treat this patient just by conservative measures. Also, the duration of the symptoms and the pathology as well, because there are lesions that even after some times of treatment with conservative measures, it doesn't resolve, then you may have to consider surgery. Other things to consider are vocal demand and the timing of the surgery. There are several voice disorders that can affect the professional voice users. Things such as muscle tension dysphonia, postnasal drip reflux, vocal hemorrhage, vocal fatigue, laryngitis, physical lesions such as nodules, cyst polyps, sulcus and scars, and arytenoid subluxation, and even vocal cord palsy. The list is by no means exhaustive. You have to resist the danger of being a surgeon and to rush into surgery. Is akin to having a hammer and everything may look like a nail for you. So bear in mind there are other health professionals that can help you manage these patients without having to take the patient to the operating room, such as speech therapists, singing coach, clinical psychologists, and sometimes even a simple rest may be all that this patient needs. You may need to consider anti-reflux medication or steroids as well. This is an example of a professional singer who came to see me. Initially, he was singing and then he felt a very sharp pain in his throat while singing, followed by coughing out some blood. He rested his voice for 5 days after complete voice loss, and then for a few weeks later, the voice returned to normal, and he was already back to singing when he came to see me. So when you look at the larynx here, you can see that there is some tension or scissoring of the arytenoids. Now, I do not know whether this appearance has always been there because this was the first time I saw the patient, or whether the snap that he felt in his larynx while singing may have resulted into this scissoring of the arytenoids. Can you make it louder? Count 1 to 5 for me. 1, 2, 3, 4, 5. Da, da, da. Da, da, da, da. So you can see significant scissoring of the arytenoids here, almost like twisting on itself. This patient, he felt his voice is fine, so no further action required on this patient. He may need some singing coaching or voice therapy, but he's back to singing normal without any intervention. There are patients that will present to you with nodules. Most commonly, the soft nodules are easily reversible with speech therapy. However, if the nodules is fully matured, then you may need to trim it off either with cold steel or laser. I normally say to the patient to trim it off because it shouldn't be any extensive surgery removing the nodules. So you can see this patient has got a soft nodules bilateral with hourglass appearance of his larynx, of our larynx. There's another patient that I saw just a couple of weeks ago, actually, and this patient is a professional voice user, but he also suffered from asthma, and he's been on steroids inhaler for quite a long time. Recently, he lost his voice completely, especially at a high note, and he couldn't sing. So video strobolaryngoscopy revealed significant irregularities on the surfaces of the vocal cord and some leukoplakia as well. So I treated him with fluconazole 200 milligrams daily for a week, and within a couple of weeks, you can see and you will hear that his voice has improved. Not 100%, but significant improvement that he went back singing, and I gave him another course of the antifungal treatment. After 200 milligrams of fluconazole, this is how his voice sounded like. Longer? Longer, Sipan. This is another interesting patient who is a soul and pop singer, and the patient has been struggling with her voice since March 2023. At that time, she had prenodular appearance on her vocal cords, and she had speech therapy, and her voice got better. And then the patient presented again a year later with what appeared to be like a hemorrhage on the right vocal cord. So even after voice rest, this hasn't resolved completely. So I had to proceed with surgery on this patient. So you can see this patient here, this hemorrhage there, and each time this patient goes back singing, it bursts and it leaks. This is why you can see different layers of hemosiderin deposit here, indicating the chronic leaking hemorrhage. You can see posterior and anteriorly as well, and in the mid portion. Watches that So this was after voice rest. So I took the patient to theater and I used combined cold still and blue laser to seal the bleeding vessels. So initially the cold still there. So you can see I've grabbed the lesion. But then I need to use the laser to just gently to seal the blood vessel to prevent recurrence. You don't need to do much here, just a few flashes of the blue laser will be sufficient. And then this patient had a contralateral lesion and a just gentle touch with just angiologic laser in there. And this is what the voice looks like. For stop 4 weeks already. This was a pre-op, you can see over there on the right side. You can see this right side is almost gone. I'm at the deep end watching. There are patients that when you see them straight away, you know that they're going to require surgery, such as patients with large cysts as well, because if you leave this too long, you'll find that it may cause contralateral damage and the voice is not going to improve on its own. So again, I use CO2 laser. Take this out. You have to be very careful that you don't go any deeper than the Ranke's space. Otherwise, you risk having a permanent scar. And let's listen to the voice. Just 8 week would stop. You can see it was the left side. Completely back to normal.
Tonight I'm gonna have myself a real good time. I feel alive.
There are times whereby what you see on the surface, it may not be the only problem. Again, this is another singer who came to me with loss of voice at a high pitch. And when you look here, you can see what looks like vocal cord process granuloma. But actually, it's more than you see here, there are lots of other pathologies. I'm just going to play to you and then you see if you can notice that. So you can see the medial surface of the vocal cord. There are some sulcus there. There is also muscle tension. If you look at the arytenoid, the right side is squeezing underneath the left side. And maybe that is responsible for the nodule, for the granuloma. You can see the granuloma squishing posteriorly. And then this patient cannot close the phonatory gap. I believe
worries me this kind of thing.
this
How you hope
patient
to let
is trying hard on the muscle tension to close his vocal cord because there was a sulcus there, and this pressure on the vocal process resulted into the granuloma.
alone and occupy your waking up. But I wouldn't have on. Sing again, the high pitch.
So I just like to point to you the pathologies that I saw in this case. So sometimes when you see something that looks obvious, if you investigate deeper, you may find that there are other pathologies that you will need to address. So this patient has got asymmetry of the arytenoids. There is diminished mucosal waves. There was sulcus and scars. There was use of false code. There was supraglottic compression and the phonatory gap.
Just the ocean or the whole thing? Okay. Cross every ocean for the sake of locomotion.
So
Sing.
the compression, the supraglottic compression there, the arytenoids on the right side, and then on the left side, there's more compression on the right side, the one that has got the vocal cord granuloma. So intraoperatively, this is what I noticed. So I noticed this patient had varices. There was scar, there's granulation as well. So what I did was I used quite a lot of combined therapy, surgical option. I used the blue laser for the varices and the granuloma, and I injected depomedron into the granuloma and dexamethasone into the sulcus and scar. You have to be careful not to inject long-acting steroids into the vocal ligament because there could be risk of atrophy. So this is the pictures from intraoperatively. So you can see the top picture there. When you just look at it, you could see that the medial part of the vocal cord is slightly shallow. And you can see the granuloma on the right side, but on the opposite side, underneath the vocal cord edge, there is a varices there, which is very difficult. It was difficult to see in the clinic. Again, on the right side, when I retracted the vocal cord with the free air, you can see there's a sulcus here with my free air digging into that. And there's another sulcus in the medial surface of the right vocal cord. You can see it's more obvious here. This is all scar tissue there. You can see sulcus there. So I injected dexamethasone there underneath the sulcus, and I removed the granuloma with the blue laser. And this is a patient 1 month post-op. Remember, the granuloma was on the right side. You can still see some residual steroids there in the right vocal process area.
That's brilliant. Absolutely.
Well, in the earlier preoperative photo, you will remember that phonatory gap, and also there was the vocal cord granuloma stopping the vocal cord from closing for it.
So, worries me this kind of thing.
I'm glad to say that.
How you hope to live alone and occupy your waking hour.
So, in conclusion, quite often you plan to go and remove a simple cyst, and under general anesthetic, you may come across things that you were not expecting. But also, even if you treat the surgical lesion itself, just be mindful other causes of vocal cord disorders, such as upper respiratory tract infection, reflux, sometimes even basic vocal hygiene, patient's lifestyle, substance misuse, and vocal demand. All of this can affect the outcome of your surgery. So in conclusion, there are many approaches when it comes to managing the professional voice users. Often, this patient, you may have a long-term partnership with them. So a tailored surgery may be the best way forward in these patients, and not every patient has to go under the knife. Thank you very much.
Great, Jakubu. Thank you very much for this wonderful presentation, and this is very important for all our COMET members, and of course for the experts in voice in all the professions that we do know about these very interesting cases. And of course, that's why, like Austin King said, we need to work in a group. Thank you. Now I'm going to present what is the contact granuloma telling you. And this is our dear Joseph Schlomicher-Thier from Austria. He, as you know, he's a medical doctor in ENT, a laboral medicine expert, also with professor degrees, and he's also for nutrition. And he's founder of the Austrian Voice Institute and chairman of the Voice Symposium Salzburg, that he's going to invite us in August. And he's also the main doctor of laboral and artistic situations and patients of the Salzburger Festspiele. Thank you very much, Joseph. This is just some lines of your big curriculum.
Hello, my friends of COMET. I'd like to speak today about my experience with contact granuloma, and my question is, what is the contact granuloma telling you? Please have a short look to the list of literature. The contact granuloma has a multifactorial etiology. According to BQ, the three most common risk factors are pontotrauma, intubation, and reflux laryngitis. On the left side you see a normal posterior commissure without granuloma, that is a normal larynx. Here you see a contact ulcus on the left side. That is the modus of an hammer and anvil contact granuloma, a huge granuloma after twice laser operations. And the other example is an intubation granuloma on the left side. And the key for that lesion is the vocal process. Because of the hammering effect and reflux acting on that side, and here is a very thin mucosa, and the hammering effect and the reflux led to perichondritis. That is the pathophysiological model of reflux, according to that literature in Journal of Voice. We have to think about to change the indoor pollution of the larynx. Avoid pepsin in the larynx. Avoid too much acid in the larynx who activate the pepsin. And avoid too much vocal traumas. We've done a retrospective study with 53 patients, 49 with contact granuloma on one side, 2 patients with intubation granuloma, and 1 patient with papilloma, and 1 patient with a granuloma on both sides. We have done a follow-up. Almost all patients had to complete the reflux symptom questionnaires. They were treated with twice daily protein pumps inhibitors, step down for 12 weeks and more. They got dietary advices, lifestyle change with anti-stress management, semi-occluded vocal tract therapy. The oropharyngeal pH measurement by Restec system was necessary at 18 patients to clarify the underlying reflux disease and the lifestyle habits, and they had a follow-up examination after 6 weeks, 3 months and 5 months. All the 53 patients got their reflux symptom in the questionnaire. Only 16 of them were not willing to fill out that questionnaire. More than half of the patients, 26 patients, has had a high reflux symptom index. The baseline was 13, the score 13, and only 11 patients were under the normal score of 13 reflux symptom index score. That is our histogram of the 53 patients. 37 males, 16 female, 30 non-singers, 23 singers and speakers. 12 of them had a hiatus hernia, and at 18 patients there was the pH measurement important to detect the underlying problems and to make dietary advices. I'd like to show you some examples of reflux. Here you see a mild reflux. The blue signs almost all in the green region, and that is a very mild reflux. Here you see extreme reflux, a lot of signs in the lower acid region. You see here the red bars shows that. And on the right side is a very interesting case. You see here in the first night they have he has a very deep acid reflux in the night, and the second night there's no reflux. What happened here? In the first night he has slept in his canopy at television with a low bed, low head elevation, and here he was sleeping in his own bed with a very good reflux position, higher position on the left side. So you see there is influence of positioning, and this patient has a hiatal hernia. You see here the result of the 18 patients where the pH measurement was necessary to underline the hypothesis that reflux is the source of their symptoms, and it is very useful to make a feedback with the patient, and it is helpful for dietary advices. Case 1, male, a teacher, 45 years old, conductor on the right side. We have done a pH measurement with a clear pathology result. He had very bad dietary habits, and after therapy of 3 months with our regime, he came back without recurrence, very happy, and was able again to go to school. The next case is a 56 years old female. She came to me with that voice.
Wer von Ihnen beiden wohl der Stärkere wäre als ein Wanderer, der in einem warmen
Low pitch, monotony, vocal fry type, hyperfunction.
Sonne.
hier,
Einstritten sich
der falsetto
Nordwind und
voice,
Sonne. Wer von ihnen beiden wohl
very clear. What's that?
Ton halten.
Look to the vocal chord,
Atmen.
high pitch, but now you see the intubation granuloma. Maybe you can overlook that when you only make your explanation with a high voice, falsetto voice. We have done an operation, and after the operation,
Sonne.
the voice is
Einstritten
wonderful.
sich Nordwind und Sonne, wer von ihnen beiden wohl der Stärkere wäre. Als ein Wanderer
Atmen.
There's the right side, the post-operative situation, no more granuloma. We have done the regime with PPIs, Luxvox, dietary change, and there was no more recurrences. What is my recommendation of the therapy for contact granuloma? PPI high dose, twice 40, step down, 3 to 5 months. Gaviscon alganates and Reloxan. Dietary advices, low acid diet. Change the PPI. If you have problems, you go from pantoprazole to esomeprazole. Head of bed elevation. Luxvox therapy, 8 times 4 minutes daily. Stress management and lifestyle modification. What was the outcome of the study of this 53 patient? 29 patient had a very good result. Of them, 15 patients after 3 months therapy, 7 patients more than 3 months, and other 7 patients lower than 3 months therapy. At 13 patients, there was a persistence of the contact granuloma, 8 patients with no control, twice intubation patient, 1 papilloma. That case is one of the cases of the group of persistent contact granuloma. Female, 40 years old, teacher. She had reflux problems, very stressful situation in the family and in the business. History of heavy coughing, and there was no change with twice pantoprazole 40 milligrams of the contact granuloma. On the right side, you see the result of pH measurement. You see in the evening, the night, a very clear reflux, and it was very obvious. Here, she has a very bad lifestyle and dietary program. She ate very often spicy foods and sweet foods, and that measurement, pH measurement, was under twice 20 milligrams pantoprazole, and there was no change. What is my meaning of the reasons of the persistence of contact granuloma? Maybe there is a hiatal hernia big enough for a fundoplication, and a funduplicatio would be necessary. Persistent error in the dietary regime and alcohol. Massive stress and anxiety situation. Maybe she's a PPI non-responder. She has a weak voice and hyperfunction and vocal cord atrophy, which leads to the hammering effect. Persistent vocal tremors and coughing. What is the conducting alarm telling you? Delayed acid and pepsin in the laryngopharyngeal region with BPI and alginate. Minimize the hammering effect of retinoids by Lux-Vox. Stop coughing. Head of bed elevation and sleeping in left side position is effectful. Lifestyle modification. Take food as medicine. Take the low acid dietary. Thank you for your attention, and I'd like to invite you for the Salzburg Symposium 2026 with the title Fit Your Skills in August 2021 and to 2022. Come and enjoy Salzburg. Thank you very much.
Thank you very much, dear Joseph, for this very interesting presentation. And next presenter with laser reduction glottoplasty for voice feminization, Professor Ismail Koshak from Turkey. He's a medical doctor, otolaryngologist, specialized in voice disorders and vocology, but he is also biomedical engineer and also homeopath. He owns Dr. Voice Clinic for professional voice patients and Dr. Voice Techno. This is a company for different voice equipment that we can know. And he is also giving a voice surgery voice course that I am sure it's going to be very interesting. Now we shall enjoy the presentation. Thank you very much, Ismail.
Dear colleagues, dear COMET members, I'd like to celebrate the World Voice Day. And this year also marks the 15th anniversary of our clinical establishment, Dr. Voice Clinic. I'm truly happy to be with you again. My topic will be laser reduction glottoplasty and its application in professional voice users. This technique was published in 2010 in the Journal of Voice, initially for patients who had failed cricothyroid approximation for feminization. Since its introduction, it has been widely adopted in our clinical practice, not only for revision cases, but also for individuals with high-pitched voices, including both males and females, aiming to feminize and create a more youthful voice quality. And the male, female, and children's vocal folds are different because of the androgenic hormones and growth hormones. Actually, first of all, the growth hormones makes the vocal cords grow, but the androgens has a great effect on the tissue. On the right side at the bottom, you can see the epithelial layer of the vocal fold, and the stained cells are the androgen receptor stained cells. And you can see in the males, the vocal fold layers are thicker and more rectangular in the vibrating portion. In females and children, they tend to be more triangular shaped. And when we reduce the tissue layers and reshape the vibrating portion, we can achieve the desired voice change. In the blue arrows you can see, we go down, we reduce the male layers, it is feminization, but actually it's demasculinization, and we go further, it's juvenation. These are the steps of the laser reduction glottoplasty. We perform the surgery under general anesthesia with laser safety, and we use carbon dioxide laser. We reduce the epithelium, superficial lamina propria, deep lamina propria, and vocalis muscle. We preserve the medial third of vocal folds integrity. And the glottoplasty phase is very important. We tense the medial flap over the MLP, middle lamina propria, and stabilize with sutures. We use H0 polygalactin absorbable sutures. First of all, I'd like to correct a common misunderstanding among our colleagues. Surgeons who are not familiar with this technique often assume that the results are comparable to those of muscle reduction procedures such as thyroarytenoid myectomies. However, these are fundamentally different techniques. In laser reduction, glottoplasty is not a muscle reduction technique only. Rather, it reshapes the vibrating portion of the vocal folds. Reduction is only the initial stage of the surgery. The critical aspect is the reshaping and repositioning of the vibrating segment to a higher frequency range. This is achieved through suturing with a particular focus on optimizing the medial vocal fold vibratory capacity. And this is the steps. These are the first step. The step here is we use the carbon dioxide laser. I use 1 to 2 watts of ultra pulse laser mode. We preserve the medial third. We go deeper and reduce the mucosa, superficial lamina propria, and preserve the middle lamina propria. Reduce the deep lamina propria. We approximate and stabilize them. Now I'll show you the video of the technique. Actually, this is a historic video recorded in 1999 featuring the first patient who underwent laser reduction glottoplasty. Since then, the technique has remained unchanged. The patient had ambiguous genitalia and referred by an endocrinologist. Let's see the surgery. I'm reducing the deep lamina propria now, and you can see the vocalis muscle. I go deep to 5 millimeters, 3 millimeters, depending on how much do I need the fundamental frequency lift, and I suture it with H0 Vicryl polygalactin sutures. And let's see some cases, the results of these cases. In the first case, this is a male to female transgender patient seeking a more feminine voice. In our clinic, we use a visual analog scale to evaluate the same voice sample across multiple dimensions, including masculinity, femininity, and childish quality. Each parameter is rated on a 5-point scale. To shift a masculine voice toward a more feminine or juvenile character, we plan laser reduction glottoplasty. You can see the M is masculinity of this voice sample over 5, femininity 4 over 5, and no juvenile quality. Let's listen to the voice.
A
12'ye kadar sayıyoruz.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Hey diyoruz.
Hey.
Let's see her voice after 2 months.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Kuvvetli bir hey diyoruz.
Hey.
Uzun bir A. You can feel that her voice masculinity level is gone. It's completely in feminine quality. Let's see in the long term.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Uzun bir A de.
A.
Çok güzel bir hey de.
Hey.
Bir daha hey de.
Hey.
İnce hi.
Hi.
Bir daha hi.
Hi.
The results are always better in the long run, and the voice settles and becomes better in use. And let's see her stroboscopic examination. These are completely 2 vocal folds, symmetrical vibrations, and a little bit posterior chink. And after the surgery in the long term, the open quotient is more profound. Yes. Let's see another case. This is a very interesting case. She is a 16-year-old female with a history of androgenic hormone treatment 1 year ago, resulting in a deep masculine voice quality. And I performed laser reduction glotoplasty.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Bir kez daha.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Tekrar kuvvetli bir hey.
Hey.
U-O-A-E diyeceksin.
Uay.
She sounds not like a girl. She sounds like a boy. That made her very unhappy. And you can listen to her voice after 8 months.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Uzun bir A de.
A.
Hey de.
Hey.
Bir daha kuvvetli hey.
Hey.
Var. Hey.
Hey.
İnce hi.
Hi. Hi.
He can do glissando, a smooth glissando. Until now, I showed you the cases with the gender assignments, and our main concern for professionals is their ability to sing. And in nasal reduction glottoplasty, the singing ability is not distorted, and so in some cases it's very helpful, especially when the vocal folds are thicker. The ranges becomes lower. When you thin the vocal cords, the range increases. And this is a case. She has a constitutional androphonia. She cannot sing, and her voice sounds like a male, like a boy, and she's 21 years old.
1, 2, 3, 4, 5, 6, 7, 8, 9.
And her voice after surgery, now she can sing.
Ay var ne tek bir yıldız, her yer karanlık ne ıssız, göremiyorum. Sen yokken ne gece ne de gündüz, ne ay var ne.
Yes, and she's happy with singing. The next case is very interesting for me because I did the surgery 15 years ago, and the next case is a 21-year-old female, and she was an amateur who was selected for a TV show following an audition, and she's cast as a high school student of age 17. But although she's young, her voice tone appears deeper than expected for her role, so she wanted a...
Günler, haftalar,
Published
aylar
voice,
geçti.
juvenile
Anlar
quality.
yaşadım geceler boyu sancılı.
This is our voice
Gün
before
doğana sabah
surgery.
güneşi uyandırana kadar. Ta ki akşam soğuğu yüzüme göğsüme vurana kadar. Avunurduk sabahın solgun mum gibi yanan ateşiyle. Isıtırken kalbimizdeki karanlığı küçücük bir ümitle. Mevsim kış oldu, halen içimiz sıcak. A yerine olta attık, yeterdi bir nefes.
And after the surgery, her voice becomes a little bit more juvenile. Let's listen to it.
Bugün Women's Health dergisi Ekim sayısı için harika bir çekim yaptık. Bu çekim için başta Hande Hanım'a, güzel kıyafetlerim için İrem'e, çok güzel olan saçım makyajım için Selma'ya.
Her show became very popular at that time, and she is one of the best known actors. She is the best known famous person in Turkey now. She did a lot of movies and acting, and this is one of them. And her voice still remained the same. She is now 35 years old.
Sette telaş hiç bitmez. Aralarda mükemmel bir an yaratmak için ise Philips'in en iyi kahve makinesi Cafe Aromis yanımda. Taze çekirdekten mükemmel lezzetteki kahve.
Yeah, this is another case. He's a professional singer, a rap singer with a limited vocal range and a deep voice. He had difficulty in performing glissandos. To compensate that, he's trying to increase the articulation rate, and he's considered one of the fastest rappers among his peers. He seeks a lighter vocal fold, improved glissando ability, and he wants to increase the capacity of his tones and sustain his higher pitches. His vocal ranges at between G sharp to B. It's about 4 semitones. Let's listen to him.
Şart, 2 şart, 3 şart bu. İlk şartız, şart hızdan dur. Pet şart gibi bütün mecra bu. Burada 1 şart, 2 şart, 3 şart. Beteri benim, defteri ver betimler değilim. Rap demeden de belen gelip her kuştan yer benim bitmedi pilim. Bak bakalım tam pro iyi mi? Taktikler tank topirim. Bu övünmekten fazlası milyonda birim. Tek bana emeklere aykırı tarz, benim ekranı sığmayan sabit kalmadı destek. Aslımı resmen saf, benim hızlı krallık turistik. Rhyme deli bile gelemedi benim ederim. Ona belirtim o şaka beni bul demedi bana bile ulaşamadı. Kapadı gibi dolu kapadı beni bile bulacak.
After the surgery, he became more capable of increasing his pitch, and he can control his higher tones, and his range changed and shifted upwards, and his efficient voice started from the F sharp to the next octave. With a slower, more controlled delivery and the ability to sustain higher notes. Let's listen to his results after surgery.
Gözüm dalıyordu yükseklere, giderken takıldım tüm seklere. Üstüme bastın düştüm yere. Bir gün bulutlardan yere ineceğim, gökdelenden hepinize küfür edeceğim. Üstüme bastın kalktım yine. Gözüm dalıyordu yükseklere, giderken takıldım tüm seklere. Üstüme bastın.
Yes, these are the results. I did a lot of cases like that. And as a conclusion, laser reduction glottoplasty is a less popular, but a very effective technique to increase pitch and gain a feminine and juvenile voice quality. It is safe, and the results are very satisfactory. Compared with other feminization techniques, patients are more likely to preserve their singing capacity. Complication rate is low, but requires technical experience. Thank you for listening, and we're starting an online course because of our 15th anniversary. It's the Advanced Phonosurgery 2026, and it starts at the end of May and continues until the mid of July. Thank you for listening. Waiting for your questions.
Thank you very much, dear Ismail. So as we see, there are many approaches in order to have a better artistic voice. And I would like to say hello to Ana Gloria Ortega from Mendoza, Argentina, also to Xijing, and of course to Ramon Hernandez from Venezuela. Xijing is from the United Kingdom. Now we shall be celebrating the voice that globalized fado, acoustic phonatory characteristics of Amalia Rodriguez throughout her career. And this is Pedro Pestana, as we know. Dear Pedro, he's PhD in language development and disorders. He's also bachelor in speech language pathology. He is a professional singer in fado, and he is also making research in professional voice use, speech and singing for many, many years. He also has a very interesting research about animal-assisted therapy, hippotherapy, and therapeutic writing. Let's hear and enjoy Pedro. Thank you very much, Pedro.
So good afternoon, everyone. It's a pleasure to be here with you celebrating the World Voice Day at the COMAT session. It's an honor. So today I'm bringing to you the most famous fado singer ever. She is Amalia Rodrigues, as some of you may have heard before. So off we go. We are celebrating the voice that globalized fado. We are tracing the acoustic phonatory characteristics of Amalia Rodrigues throughout her career.
Moraria da velha Rua da Palma, onde um dia deixei presa a minha alma por ter passado mesmo ao meu lado certo fadista de cor morena, boca pequena e olhar trocista.
So Amalia was born in the back streets of Lisbon in Portugal. She transformed fado, a raw melancholic folk tradition, into a global art form, becoming the most celebrated Portuguese artists of the 20th century and the defining voice of a nation's longing. She was born in 1920 and died at 79. Her career lasts for 55 years and she performed several thousand shows. She performed at the perhaps most famous place in Portugal for fado performances, which are casas de fado or fado houses, if you will, cabaret clubs, nightclubs and casinos, musical theater, cinema, radio, television, and major concert halls and opera houses around the world. So, as you may see, she performed all over the world, being the most dark spots, the places where she performed at. She recorded over 150 albums and 79 recorded songs. Her voice was not formally trained and she was self-taught throughout her career. She was lyric soprano in the 40s, mezzo-soprano in the 60s, and later a contralto in the 80s and 90s. She is known having an exceptional vocal range. She has a timbre with a chiaroscuro quality, a short, controlled vibrato, precise intonation throughout her career. So, however, a long career had some health setbacks. So that is a quote from her. My voice has a certain quality. If it doesn't come through, it's because they are taking it away. So she's talking about foreign sounding engineers. Between 74 and 76 she had a severe depression, and stating that her vocal capabilities were on the decline, her singing starting to falter. She suffered some cervical surgeries in the 84 due to a malignant tumor in carotid. And the Barco Negro, which made her the international singer she was at the time, that theme is beyond her control. She started feeling that. Amalia did think about suicide once, when she was faced with a throat operation that might have altered her voice. In the 80s and in the 90s, the voice was visibly deteriorating. If I don't hold onto the shawl, my voice doesn't come out the same way. I twist it and my voice comes out stronger, said Celeste Rodrigues, her sister that I had the opportunity to meet in life. So our workflow today, I got some original recordings along her career. I removed the instruments using the tool Ultimate Vocal Remover, and then I analyzed it using RecVox to make the vocal range profile, or VRP, and Vibratoscope as well. So the song that I chose was Ai Moraria, because this was the song that she sang most during her career. She recorded it a lot. So let's hear the differences. The 1945 recording.
Ai, moraria das procissões a passar, da serraiva saudade na guitarra do sol.
The 57 version.
Ai, moraria das procissões a passar, da severa e voz saudosa na guitarra solução.
As you may see, she decreased a little bit the key.
Ai, moraria das procissões a passar, da severa e voz saudosa na guitarra solução.
As you may see, there is a lot of changes in her voice, but in her speech too. But today our issue is the voice. Our major concern is the voice. She decreased the semitone from the first to the second recording, and another semitone to the third one in the third recording. So what is interesting is that in the second one, in the 57 version, the area of the voice range profile increased a little bit, and it may be because this was a live recording. The fundamental frequency reduced because she was aging. HNR decreased also because she was aging, and vibrato rate was decreasing as well, even though it was noticeable and very beautiful indeed.
Ai, moraria dos rouxilhões dos vareirais, dos vestidos cor-de-rosa, dos pregões tradicionais. Ai, moraria das procissões a passar, da severa a voz saudosa na guitarra solução.
This was a late version of a late recording of the same song, and in 96 she went into the studio for the last time to check on the condition of her voice, not his voice. She realized that her voice was no longer up to the task. She returned home and never tried to sing again. So thank you so much for having me. I will end this up. It was a pleasure to be with you and to share this moment, this very special day. Thank you so much.
Thank you very much, Pedro. So as we see in this long career of Amalia Rodriguez, there have been changes, and this is interesting to have here that. Thank you very much, Pedro. Now, our presentation is voice biomarkers in singers. And this is from Ramon Hernandez Villoria from Venezuela. Thank you, Ramon. As we know, he is a medical doctor for nutrition, and also he's a linguistic, and he has a public health degree, and also as for nutrition. He is a speaker in broadcast performances, and he belongs to the Union of European for Nutrition's Committee in Hearing, Biomarkers and Education. And as you know, is just some lines of his wonderful curriculum. Thank you, Ramon. Let's hear you.
Hello, dear all. Today, as we approach World Voice Day, I'm bringing up a topic that aims to be innovative in how we consider our voice assessments, simple through our organization and adaptation of what many of us already do. First of all, let's review the concept of a biomarker. What is a biomarker? What first comes to mind when we hear the term is the biochemical markers obtained in blood tests. However, biomarkers have been defined as a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to a therapeutic intervention. Yes, biomarkers can be molecular, but also of other types. The important thing is that they are measures of physiological changes and have a clear diagnostic, predictive, or prognostic value. Of course, they entail a financial cost within the healthcare system. A fundamental characteristic of biomarkers is that they are specific, effectiveness, and efficient. This means that the objectively measured characteristics does with the claims it does. A narrow focus is essential for good specific. Within this context, voice measurements are physiological measures that can serve as biomarkers. Why have we chosen the term voice-related instead of vocal or voice biomarkers? Although the majority of the literature for several years have opted for the latter two terms, from a phoniatric perspective, we know that the voice is a multidimensional phenomenon which we assess using a variety of tools and not strictly through the digital analysis of the sound signal alone. The purely digital analysis of the sound signal has led to the classification of the biomarkers included in it as digital biomarkers. Acoustics alone is not sufficient, but linguistics, semantics, and vocabulary do not reflect glottal function. Relying on the publication of Lichten et al., a good understanding of voice physiology is based on 5 dimensions, as seen in figure: self-assessment, perception, visualization, acoustics, and aerodynamics, all of them reasonably integrated with the medical interrogation and with some screening tools for concurrent problems. Except for acoustics and some of the aerodynamic measurements, none of these dimensions can be objectively measured. Scores of evaluation are made for patient complaints and listener evaluation and are usable with AI. With this subtle yet significant difference in terminology made in 2023, Dr. Mikko Moorman, Dr. Matt Pedersen and I established the Biomarkers Committee of the European Union of Phoniatricians, which was soon joined by other colleagues. A study conducted by committee members found that over a period of 10 years, 78 papers without using AI studied parameters that, based on voice analysis, clearly and accurately identify laryngeal and extralaryngeal diseases or conditions, particularly those of neurological or pulmonological nature. What was found? The eventual markers found are supported by a base of more than 7,000 patients and more than 1,500 controls. The markers found in the non-A papers were HNER, harmonics to noise ratio, fundamental frequency, intensity, jitter, shimmer, and BSI. Although other markers were also used with some frequency in the papers, these were the most recurrent. Different AI methods in the first major wave of global use of these tools were used in more than 20 papers, analyzing a large and varied number of parameters, making them difficult to summarize. The voice-related biomarkers are a set of parameters centered on the glottal pressure function, but these biomarkers functions as a multi-parametric and multidimensional based complex construct. Multidimensional biomarker for glottal closure function leads the committee suggests keeping at least the following parameters considering their importance in the glottal closure function: GR, BAS test, BHA, HNER, visualization, and MPT, maximum phonation time, also glottal closure quotient, and glottal inverse filtering. How we can translate this to singing? To apply the concept of multidimensional biomarker glottal closure to the singing voice, I suggest approaching it from a specific adaptation that considers the unique demands of singing: tonal range, dynamics, registers, vocal stamina. This involves maintaining the multiparametric structure but adjusting each domain to the singer's specific circumstance and including items on flexibility, register transitions, vocal fatigue, and breath control. Let's look at these possible adaptations. Despite the facts you can read in this slide, no well-established, widely validated GR-VAS adaptation explicitly called singing GR-VAS appears in the supplied literature. Research has investigated singer-specific perceptual cues such as passaggio, vibrato, and spectral harmonic changes, but a single standardized singing GRVAS scale is not shown. SVHI-10 is commonly used instead of the generic VHI or VHI-10 in singer-focused research and clinics, and supplementing with quantitative vocal workload, vocal dosimetry, or structured self-report of single load is also described. Although the workload methods are less standardized than the SVHI. There is a coherent body of works in singing voice science that keeps HNR as a core periodicity noise metric while extending analysis to dynamic tasks, crescendo, diminuendo, register transitions, perturbation, and strip condition. Cepstral measures, spectral projection metrics, including SPR, however, standardized singer-specific protocols that unify all of these in one validated framework remain limited. Targeted video-laryngoscopy tags for singing are described in the singing voice imaging literature, but the strongest direct evidence for imaging tags, for singing tags with detailed vibratory cycle analysis uses high-speed video endoscopy plus chymography or electroglottography, not the conventional stroboscopy. Measuring MPT across different phonation types, adduction, brightness versus breathy, because it changes with glottal wave valving, airflow, and quantifying glottal closure, contact quotient, CQ, in singing using glottal inverse filtering and related instrumentation through much of the singing CQ literature use electroglottography on or high-speed imaging rather than inverse filtering alone. Inverse filtering alone. What practical experience do we have evidenced in the literature? GRVAS used as a perceptual test in proposed biomarker measures and clinical protocols for singers. Perception in clinical batteries is recommended along with the instrumental test for a multi-dimensional voice. What SVHI and VHI used in multidimensional assessment studies of singers is preferred SVHI-10. So we've recommended VHA as a part of standard batteries along with acoustic and aerodynamic parameters. HNR measured as part of the acoustic assessment and studies with singers. Jitter and shimmer included in acoustic analysis to identify tonal instabilities and changes. Quantification of phonation through the phonetogram, LTAS, spectrograms characterize the singer's range and performance. Diagnostic laryngoscopy and stroboscopy included in clinical acoustic protocols for opera singers for instrumental evaluation is part of the things that are recommended in multidimensional evaluations. MPT reported in multiple studies and protocols on singers S over Z ratio and phonation quotient used as aerodynamic indices in clinical evaluations of singers. There is insufficient evidence on the explicit use of the glottal closure quotient in the listed studies, insufficient evidence on the explicit use of glottal inverse filtering. Conclusions: generating a framework based on the idea of biomarkers in relation to the voice is a promising idea for the organization and systematization of dispersed elements that need to be integrated into a set of indicators that deliver a value of the state with the rigor of detecting biological changes in a specific efficient and effectiveness. Due to the nature of its specific stacks, singing requires an even more specific adaptation of the construct. This is still in its early stage, as the complexity and variety of stacks complicate the ease of measuring and standardizing measurements. Perhaps directing AI resources towards the development of tools for integrating and analyzing data from the study of various parameters simultaneously with the execution of certain specific single stacks could offer us a practical solution to the problem of integrating what that resulting data can tell us about biological changes we want to find even before they become very evident. This is a bit of the most important literature. Thank you. Have an enthusiastic World Voice Day 2026.
Thank you very, very much, dear Ramon, and happy World Voice Day for everybody. But we have still some very short remarks. First of all, I want to congratulate all the presenters for today, because we have a broad topic situation today, from hygiene and from education and from examination and surgery, and this wonderful topic about biomarkers. Congratulations to our dear COMET members that had a wonderful artistic voice specialist informed COMET session in PVOC 16 and Voice Istanbul. And I have a great surprise for everybody, because all our dear speakers allowed us to put the conferences in our webpage, and our dear Pedro Pestana made the recording. Thank you very much, Pedro. So you can enjoy COMET PVOC 16 Voice Istanbul very soon in our webpage. Thank you very much. The next one, please. And also, I would like to remind you that if you have some information that from your curriculum or from your data that you want to put in our webpage, please send that to Isabel. Next one, please. And of course, also, I want to congratulate the organizers from the marathon, the UEP, Union of European for Nutrition's Voice Marathon, to celebrate this Voice Day webinar, mainly our dear COMET member Ilter Denisoglu and John Rubin. But of course, we have 21 COMET members being in this wonderful marathon. Ron, Bob Satalov, Liza, many of others. So here are the list. And of course, I shall put that also in our webpage. Thank you. And in this World Voice Day Marathon, they have also many topics. Next, Karina, please. Many topics, very interesting topics. And as you know, this is a great effort from all the organizers and the speakers to be many hours in this voice marathon, that it's going to be really wonderful. Next one, please. So congratulations to all COMET members. There are many topics, as you see here, aging voice and some others. I cannot read them all, but we are having a lot of presentations, very interesting presentations, and of course discussion. And if you want to see the program, you can go to our webpage and you will find all the program. Next one, please. And of course, great thanks also to Professor Han August. He's also a dear COMET member. And I want to remind you that our dear Robert Satalov and Ron Scherer and Johan Sonberg and their groups are going to have a wonderful annual symposium, 55th anniversary in Philadelphia. So don't miss that. It's going to be great. Next one, please. And of course, we have some more announcement. Next one, Karina, please. And this is 11th July. We shall have online session with superior laryngeal nerve pathologists. If you have something to propose in this topic, please do that, because we are organizing the program. And Joseph has already, next one please, Joseph Shlomi-Hertia has already announced his wonderful voice symposium Salzburg. Here you have the announcement also in our webpage from Rolando Villazón, also our patient. And of course, it's going to be a great Fit Your Skills in Salzburg voice symposium. So everybody invited. And thank you very much for being honorary member, dear Joseph. And 5th of September, Care of the Artistic Voice Professionals. Please write your topics, because we don't have so much time for this webinar, so I need to organize the program. Next one, please. And now we shall give the word to our dear Katrin Neumann. She is going to talk about the Münster, Germany Annual Conference COMET 2026. Yes, dear Katrin. Karina, please share with Katrin.
Yes, thank you very much, dear Eugenia. Hello to everybody. And if I can share, then you need to close this, I think. Then I can share my short presentation.
Karina, ¿le das entrada a share, please?
Yes, one moment.
Okay, I can share already.
Okay, Katrin.
I guess I can share already. And this is already the most important, slide, because you see the meeting will be, the conference will be from 15th to 18th October in the very nice city of Münster. And here are the people, many of you, who already confirmed that they will be there and give speeches. And fortunately, our main keynote speaker is Johan Sundberg. I feel very honored. And even Marc Bouchelier wants to come to Münster. So it's worth to come. And if you see whom we have here, including Christian Herbst, Matthias Echternach, Kitty Verdolini, and you can read all the names, Philipp de Jonker, John Rubin, and also Ramon is coming, Malte Koop, Lisa is coming. I hope you give a workshop, Lisa. And Markus Hess, Claudia Spahn, Bernhard Richter, Franco Fussi, Erko Bianco. That's really great. Peter Pabon, wonderful. and Korea. I don't want to read all the names for you, but I want to encourage you. These are the people I asked at first, would you come to Münster? Is it worth to have the conference there? And nearly nobody said no. But now there will be a call for abstracts, and it should be very short abstracts so that we have a title and an idea who else will come and wants to come to Münster. And the registration fee, I wanted to keep it under 500 euro, but it covers the main things: the registration, our meeting venue, and all the meals, dinners, and even an opera ticket. So, where's Münster? It's in the west of Germany, north to Cologne, and it is a city, has 320,000 inhabitants, more than 40,000 students. It has a very old and nice university, very famous university. So it's a historical city. It has been founded by a monk in 797, started with a school and later on a cathedral, which is still there, the cathedral, you will see it. And it was the city where the Peace of Westphalia was concluded, ending the 30 Years' War in Europe in 1648. You will see this nice building where it happened. And this is our venue, the Park Academy at University Hospital Münster with the hotel. I have still 20 rooms, not very expensive. Here, double and single rooms for guests from the Comet, which is the former officers' mess of the Oxford Barracks of the British Army. Very fancy. You will like it. And nice meals, lunches, and things there. On October 15th, you will arrive in the afternoon, many of you, I hope, going to the hotels. And at 6 in the evening, we have a reception in the theater of Münster with drinks and food, specially for us only, and introduction in the opera La Traviata. And then we all visit, all of you who want, the opera La Traviata by Verdi. I think this is a very nice start. And October 16th, we start early with scientific presentations and workshops because we have so many. And in the evening, we have a conference dinner in the Castle Wilkinghege. Münster is surrounded by about 110 castles, which are all surrounded by water, the water castles. Very famous, very nice. I see you smile, Eugenia. That's nice. That's wonderful. Yeah. And we have also then a concert of the very famous Cubanian. He is coming over to us, flamenco guitar player Renier Marinho. Maybe you know him. He is wonderful. He is great musician. On the next day, we again start with scientific presentations and workshops. And in the evening, we have a dinner in the wonderful Italian restaurant Caputo's, belonging to Mr. Caputo. And he has great cuisine in the old city of Münster. And if some of you, I hope so very much, want to remain a little bit longer on Sunday, we will have some breakfast and cultural activities in Münster and the surroundings. So that's what I want to say. Come to Münster. We will send out more invitations. Send in your abstract or come and be the audience. That would be wonderful. Thank you very much.
Thank you very much, dear Catherine. And as you know, dear Comet family, the annual conference is very important, not only because of the very high academic level of the Comet members who are the speakers, but also from the environment and the atmosphere that the Comet family has through 56 years already enjoy in the different annual conference like Mexico, Santa Fe, Houston, Denver, Berlin, and so many places that we have had this annual conference. And this is the time for our dear Catherine to be the host, and we thank you very much, dear Catherine, for all the organization. And as you know, Catherine and me, we need to decide which program is going to be, and also the Comet members are very welcome to propose, and there are some special guests that we shall talk about. Thank you very much, Catherine, and I hope you can come, because annual conference, as Austin said all the time, that it's a very dear situation in order to be face to face and to embrace us and to say hello and to talk about many things that sometimes we cannot talk online or in big congresses. So this is, of course, annual conference open to the world. Everybody is invited, but the speakers are the Comet family. And I am very happy that Johan Sundberg, in his 90th anniversary, will also celebrate with us. Thank you very much, Catherine, and thank you to
wonderful.
all. And please save your date, save everything. And the next one, please. I'm going to go very, very quickly. Don't forget the philosophy of Comet. You may read also the articles, because, as you know, we are going to change board in November in our General Assembly. So, and it is the spirit of Comet. That's why we are unique to exchange knowledge and ideas, but also to facilitate the referral of a singer or actor to one of these Comet members, and to disseminate scientific and clinical knowledge. That's why we have all these Comet members, special organizations in our webpage. Next one, please. And it is important that, you know, for the next Congress will be at the Voice Foundation as a special Comet session in the 2027, and in the 2028 will be by Pedro Pestana in Oporto, Portugal. But don't forget that Comet organize also their own specific congresses, as Catherine is doing this year, but the program has to be elaborated with the president. This is slightly different because we need to keep on with the spirit of the Comet family. But it's open, of course, the academic for the whole voice community for all the world. Next one, please. And this is also important for our bylaws, but you are encouraged to give lectures dealing with artistic voice. And please let me know, so you can be supported academical by us, by Comet or board. It is important because Comet has one of these spirit goals to disseminate all the artistic voice knowledge and experience that our Comet members have, as you have seen today. Next one, please. And very quickly, I don't want to bother you more, but don't forget that the members are obliged to be one of every 3 successive ethics to maintain tip status. And also they have some obligations to be active, to be with Austin and Isabel. Austin is our treasurer, and he is very, very detailed analyzing, because to be obliged to pay into the membership fees, and the amount that we decided is just 70 euros per year, and to be active we need to be 3 years in order. And of course the speakers, the Comet members that's going to be speakers, they need to be active for all this. And The next one, please. So don't forget this administrative and very important situation, because COMET is a small group. We have our dues, our fees are from the members, sometimes donations from the annual conference, like from Catherine, and sometimes from other events, and of course, legacies and benefits. So the next one, please. So you can read everything in our articles, and I don't want to bother you more with this because we have already talked about that. The next one, please. And don't forget that we have the marathon. I invite you. I'm going to talk about respiratory allergies and its treatment to avoid voice pathologies. There are so many of the COMET members that have wonderful topics. Next one, please. And enjoy COMET activities. Invite your groups. Don't forget that our webpage is very rich. We have today the 27 online academic session. And because this is a World Voice Day celebration, if you have some questions or announcements, please do shortly, because we cannot have the long discussion that we usually have online academic sessions. Please let us know if you have. Can we please everything, Karina? It's okay. And we shall have. This is for the last time. Many of your dear faces. And the next one, Karina. And if you please open for the photo today, Karina. Yes,
Eugene,
wonderful.
do you mind if I say one important thing?
Yes, please, Pedro.
Julian just told me today that unfortunately Professor Adrian Forson passed away yesterday. So it's a sad news to us. Adrian Forson from the UK.
From UK. Yeah, wow.
So unfortunately John is not with us, John Rubin, but Julian will send you an email. I just thought it would be useful for everyone to know that Professor Forson passed away yesterday.
You mean Professor John Rubin?
No. Professor Adrian Forson.
Adrian Forson, who did a lot of work, for example, yes. With...
I'm very sorry. I'm sorry, but my internet is not working.
Signal analysis
today. I am very sorry. And if you write to me and send the information, so we can put that in the webpage.
Julian will do that.
Thank you, Pedro, for the information. Well, dear friends, I thank you very much for your presence and, of course, for the great presentation that everybody did. And as we know, we are already 2 hours here online. And, well, I thank you. And we leave the discussion of granuloma, surgeries, and biomarkers, and, of course, all the career for Amalia Rodriguez for the next time. Thank you very much. And please make photos, Karina. And thank you very much, Austin, Tom, Sarah, Catherine, Liza, Alan, Joseph, Ron, Pedro. Many kisses.
Thank you so much. Bye, everyone.
Bye-bye.
Bye, everyone.
Bye-bye.
Thank you so much.
Bye-bye.